Thank you much. Thank you so much for presentation. I know this is a last talk. I will try to be short. I think I'm one of the few people in this room that I'm not a transplantologist. And so I think there is a challenging case and would like to know also your thoughts about the case. I will basically present a clinical case, but we have several these kind of clinical cases. That's why we decided to know your opinion about this. Let's start from the neuroblastoma. Neuroblastoma is the most common extracranial tumor, solid tumor among children. In USA, per year, 650 cases are diagnosed. In Armenia, we see from 4 to 5 cases, and half of them are high-risk neuroblastoma cases, as it's the same worldwide. And 5-year survival of high-risk neuroblastoma is 50%. But if we are proceeding with an intensive, comprehensive, multimodal treatment, which includes induction with chemotherapy 6 cycles, and after the second cycle, harvest of stem cells, and then the surgery, consolidation with stem cell transplantation with myeloablative regimens that you see, tiotepa, cyclophosphamide, carboplatin, etoposide, and melphalan, and also radiation therapy if we have a residual tumor. And post-consolidation treatment, immunotherapy, for instance, anti-GD2 agents, plus cis-retinoic acid. There are different approaches in European guidelines and in COG guidelines for the neuroblastoma treatment related to the transplantation. European guides use single transplant with the myeloablative regimen of busulfan and melphalan, but while COG guides use tandem transplantation. I was able to find this study which compared event-free survival for 3 years. And so we see the difference for the tandem transplantation and single transplantation, 13.2%. This is a clinical case. 6-year-old female was diagnosed with a poorly differentiated high-risk neuroblastoma, M stage, with unfavorable histology and with anemic amplification. Imaging examinations revealed retroperitoneal tumor with lymphadenopathy and involvement of bones and bone marrow. And here you can see the oncomarkers level of ferritin was quite high. Histological and immunohistochemical examination included poorly differentiated neuroblastoma. For this patient, we started the treatment and we reached to the consolidation phase, but unfortunately, after the stem cell transplantation, we're not able to go further because we lost the child. So before starting the consolidation with stem cell transplantation, patient was infected by COVID-19. Afterwards, refractory thrombocytopenia occurred, and we were not able to understand what kind of isolated thrombocytopenia is this, because before that bone marrow was okay, and antiplatelet antibodies were detected. Of course, I understand that this is not so specific, but anyway, we started the treatment with corticosteroids and it worked. So thrombocytes reached to the level that we were able to proceed with the stem cell transplantation. After the stem cell transplantation, after the second transplantation, in early post-transplant period, the thrombocytopenia was mild, but within several months, it became progressive, and with hemorrhagic syndrome, corticosteroids and IVIG were not anymore effective. We tried L-Thrombopac, just tried, but of course, this also didn't work. Yeah, we did the bone marrow exam several times. I will tell you about this. So, and the main thoughts that we have, whether this is a progression, and of course we have bone marrow involvement, or this is immune thrombocytopenia. After the stem cell transplantation, we performed MIBG examination, which indicated progression of the disease under the question mark, and bone marrow was not active. This was very suspicious, and we decided to correlate the results with the PET-CT examination. So performed PET-CT examination, which indicated progression of the disease. And this time, PET-CT examination gave us an idea about pathological changes in bone marrow. So we proceeded with the bone marrow biopsy, and we didn't see any pathological changes in bone marrow. Over the whole period, we have never detected anything in bone marrow, although this kind of examinations indicated that we can have activity in bone marrow. So we decided to discuss this patient, and we discussed this patient with St. Jude Research Hospital. As anti-GD2 agents are not available in Armenia, we tried to include this child into the clinical trial, but unfortunately, because of the low level of the thrombocytes, we were not able to start the treatment for the relapsed neuroblastoma. What we could do just to monitor this patient and provide symptomatic treatment. The other PET-CT examination was in December. And here, what was interesting, without any treatment, FDG evidence in bone marrow and also in main pathological parts, lesions, was decreased. We did again a bone marrow biopsy, but again, we didn't see any pathological changes in bone marrow. So we proceeded then with the CT examination, and again, the same. So the residual tumor was there, but no new lesions. The child, the thrombocytopenia became progressive, and again, we tried to check antibodies, antiplatelet antibodies, and in life-threatening situation, we started to do also platelet transfusions with in combination with the IVIG. So we were thinking about the causes, possible causes of the thrombocytopenia, and progressive disease with bone marrow infiltration again was under the question because different examinations were showing different results. Maybe that could be persistent secondary thrombocytopenia. About the TA-TMA, we're not sure because it was too late after the transplantation. And also we tried to find in a literature those kind of cases, and we saw that there are described several cases, but related to the adult solid tumors. There was the one article that I was able to find, but this immune thrombocytopenia in neuroblastoma, it was not connected with our case because the child was diagnosed with immune thrombocytopenia before starting the treatment with neuroblastoma. And the corticosteroids worked well, and they could proceed with the treatment of neuroblastoma. About the TA-TMA, as I have already mentioned, it was too late for having TA-TMA. And also the hypertension was mild hypertension, which we saw in the late stages of the disease when the child was close to die. Elevated LDG, of course, could indicate the progression of the disease. Proteinuria was not significant, and we didn't see any schistocyte in the blood smear. Unfortunately, after 10 months of the stem cell transplantation, the child died. And parents decided not to do autopsy, so we're not able to understand the whole picture of this child. So if this was a progression with the bone marrow infiltration, why do we were not able to detect the bone marrow changes in bone marrow? Or if this was a persistent thrombocytopenia, if that was immune, we were not we didn't have time to proceed with rituximab or to do splenectomy because she died. But what is interesting, that we have two other patients with the same history. After the auto stem cell transplantation, the other also had progression, but the other patient's bone marrow was not involved initially. And again, he died. And now we have the third patient after the stem cell transplantation. She has moderate thrombocytopenia, it's improving, not like the cases of these two children, but still we have. So that's all. Thank you.